Welcome back to Inside Athletic Training and our Tales of the Tape series detailing the ins and outs of Tommy John surgery with experts in the athletic training and sports medicine field. On this week's episode of the Tommy John series, we welcome in Ron Porterfield, Director of Player Health for the Los Angeles Dodgers. We sat down with Ron, a man with a wealth of Major League experience, to better understand the entirety of the rehab process when working with a player who's trying to get back from Tommy John surgery. And don't forget to tune in next week as we welcome in Joe Benge, Tampa Bay Rays head athletic trainer, for the final installment of the Tommy John series. Joe will walk us through the ins and outs of the return to play strategies and planning process as he works to get a player back on the field after Tommy John surgery. Enjoy the show.
Well, we have a great guest here today for the podcast. We have Ron Porterfield, the Director of Player Health for the Los Angeles Dodgers. Ron, thanks for joining us.
Hey, great to be here. Truly appreciate it. I'm blessed to be in this podcast.
No, thank you. It's definitely our honor. So I want to start with just kind of, if you wouldn't mind, going back through the early days and your background and how you've reached the current role with the Los Angeles Dodgers and what you've done for the profession and in the profession.
Well, I've truly been very fortunate. I've, coming out of college, being an athlete, I wasn't sure what I wanted to do in life. I was fortunate to get an opportunity with the Houston Astros back in 1988. Since then, I've had great roles with not only Houston through their minor leagues, but also with the Tampa Bay Rays, and also now with the Los Angeles Dodgers. So it's been 36 good years, just starting my 37th year. And the ironic thing is that I spent 15 years in the minor leagues, 15 years in the major leagues, and now I'm in my 7th year in the directorship. But having to created the friendships that I have all over this game and all over this world are things that I could have never dreamed that I would experience. And a lot of it has just come through the ability to get involved and help give back to the profession, get involved with the Professional Baseball Athletic Trainers Society, and realizing the hard work that the founding fathers and the people that came before us put into it. And when they come back as alumni and see what has gone on in the profession and with our society, they're in awe with what has been created, what they started, and how it's developed. And that's what gives me great joy to be in this game.
That's outstanding. It's such a big piece to know where we've come from and where we're heading to. And that really kind of segues great into this entire module that we're doing here to go over the 50th anniversary of Tommy John surgery, the ulnar collateral ligament reconstruction surgery. And today we really want to dive into your knowledge base on really the first half of the rehab process from injury all the way up to the return to throwing session. So when you have an athlete, say, that comes to you and they're in front of you and they say that they have medial elbow pain, what are the first steps? What's your thought process? What goes through your mind when that athlete is facing you saying that the inside of their elbow is not feeling good?
I mean, the first thing is some sympathy and empathy towards that player because he's doing something that he's dreamed of his whole life. So the first thing I really do is just get a history of why he's having this discomfort. Why is he pitching? What position is he? Is he, that's involved in knowing who your athlete is, but getting an idea of how long this has been happening. Was it one incident? What was that mechanism that caused him to have that medial elbow pain? Then doing an evaluation and trying to pinpoint the anatomical structures and really get the knowledge of what do I feel his problem is. Is it soft tissue? Is it ligamentous? Is it tendon? Is it bony? Just trying to close my eyes and picture either an anatomy book or a previous surgery that I've had the ability to observe and palpating those structures with my own hands to try to find out exactly where his pain's at, and then deciding on what are we going to do with it? Like, has he had problems with this in the past? Is it something new? Is it a chronic in nature? Is it, get an idea, put the puzzle together, if you will. So just little pieces of that puzzle put together, something that I can relate to on whether this is something that I think I can take care of myself, or are we going to need physician intervention?
No, you bring up a great point there. Trying to be the detective and putting those pieces together early on in the process to know, and that's where your experience and history and knowledge base of these injuries really plays into it. So now, if we take that next step forward and say that this is something that we need to triage out to a physician, I think a lot of people don't understand the process the athletic trainer plays, or the role the athletic trainer plays in the process. Could you kind of go through it a little bit on your relationship with your team physician and the process from going from injury to getting them in front of your doc?
Sure. I've been fortunate to work with a lot of great physicians in the past, but I think the big thing is to kind of ease the player's mind, if you will, because they're going to think it's the end of the world, of course, but to try to just say, hey, I've seen this multiple times, and at the end of the day, everything's going to be okay. I do want to, either get on the phone or get a text to my physician or even an email as quick as possible to find out a time that I can talk to him one-on-one, away from the player, give him the exacts of what my evaluation findings were, and then kind of decide, hey, doc, do you want to see him right away? Do you want to get an MRI right away? Do you want to give it a couple of days? I look for some instructions from the physician as to how he would want to go alongside. Is this, what type of player is this? Is this player a big prospect? Is he a major league guy? Is he on the cusp of being in the big leagues? How urgent do we need to be with this? Because I know the front office is going to be wanting to know the specifics as soon as possible. So getting the doctor's thoughts are extremely important, and I can relay that information back to our front office, but kind of having an idea what we're going to do either in the next 24 hours or the next 48 hours or even the next 72 hours.
Oh, it's critical, isn't it? Just making sure that we give the physician the entire picture so that they know exactly what is going to be in front of them in the exam room. We as athletic trainers never want to be surprised, and I know our team physicians never want to be surprised. So it makes sense that you're crossing every T and dotting every I before that athlete ever is seeing that physician.
Yeah, so say that.
Go on. Sorry.
I'm sorry. There's so, not to interrupt here. There's so many times that physician might want to evaluate him before a diagnostic, and there's so many other times that based off of what I see in the evaluation, they'll say, you know what, let's just get an MRI or CT or bone scan, whatever that may be, or multiple diagnostic tests before he even evaluates the player, because it'll already give him a little bit of an idea of what we're dealing with.
And I'm sure that the relationship that you have with that physician and his or her trust in you as a clinician really does drive a lot of that early care.
Oh, absolutely. No doubt.
So say that we now take that next step and we do have to go down that surgery route, and we're staring down the barrel of Tommy John surgery or ulnar collateral ligament reconstruction surgery. What do you do to prepare your athlete? What kind of questions do you make sure that you answer for them? And what do you need to do as both an athletic trainer to facilitate that, but also as a person there with an athlete that is going through some tough times?
Yeah, I think I always like to hear the surgical need to come from the physician. And that isn't always the case, but the majority of the time, especially with the young player, I want him to hear from the physician. And then of course him ask any questions of the physician at that point in time. But I try to enhance on that side, again, be on the side of empathy with that player. For me, I need to really take into consideration the age of the player. You know, I've worked with players that are as young as 16 years old and as old as 39, 40 years old. So, you know, if that player is underage, we're going to have some parental consent if you know what I mean. But also if they're 18, 19 years old, they're still not really going to understand what's going on. So we're going to need some either parental advice. You know, if they have an agent or an advisor, I want to know who it is or, you know, what their thoughts are. Is there a second opinion going to be needed or wanted from their camp, if you will? And if so, then, you know, what are they thinking of in who they want to do the surgery, what physician they're going to choose. And then, of course, getting that set up, we're going to want to get a date. And then where are we going to do the rehab? You know, we're either going to do it in-house or sometimes you have an older player that might want to go home for a little bit. But I think the big thing is just trying to make sure that they kind of understand the specifics of why they're being recommended to have surgery, and what we'd be looking at in a time frame on the rehab side of things.
It's absolutely imperative to have all those answered before moving forward. But you bring up a great point of now we're through the surgery and now we're looking at rehab and the physical therapy aspect, which I feel that, you know, you and I really enjoy and it's been a big part of our careers. I know that. So what early conversations do you have with that athlete that's now in front of you? They're getting ready to embark on this year-plus journey of returning. Do you sit them down early on and just go over goals and this is what we are looking for, here's what we can accomplish? What are those conversations like with your athlete, and what do you try to instill in young athletic trainers going into this for the first time?
Sure. I have basically a template of my thoughts on how this rehab is going to kind of step forth, if you will. We want to put some goals together. I want them to understand, hey, these are the instructions from the physician. And then I want to lay out kind of some relatively tentative timeframes for what they're going to go through immediately post-op, how they're going to feel, how I want them to just take it easy for a couple of days, not get in a hurry to get back into doing activity quickly, and why, and then what they're going to expect when they come out of surgery, and when they're going to look to see the physician again.
Oh, that's exactly what I figured you would be doing with your athletes, making sure that everything was outlined ahead of them. And I think some of the clinicians across the league would probably echo your sentiment that that's exactly what to do is your first step and the athlete getting on the road to recovery. And to that point, you know, the staff has grown so much in the performance aspect of baseball. It's no longer just one athletic trainer or one physical therapist working with an athlete coming back from surgery. So what does the team look like at the Los Angeles Dodgers of taking a player through their post-UCL reconstruction rehab? What is that whole paradigm and dynamic look like?
So there's a lot involved in that. So not only do we have the sports medicine department, but we have our performance department. We have our recovery department, which is like our nutritionist and our dietitian. We have our sports scientist that's going to be involved at some point in regards to like mechanics and getting them to start seeing what they look like when they were really good, and how they want them to start thinking about getting back into that. We got the mental skills that are going to be helping us as far as like giving them reminders and exercises and things of nature mentally of how we're going to develop a mindset to overcome this rehab and, you know, when there's low times and high times and how to overcome those and stay positive and go in a good direction, as well as mental health, which could come in and how to deal with it on a daily basis, or how to deal with downtime when you're at home, or how to deal with downtime when you're with your family or you have kids and things of those nature. So there's buckets of various entities that are completely, totally involved in that. They may not all be involved at the same time, but when that person's coming out of surgery, there's going to be different phases of the rehab. When the protective phase, when they're probably in a brace, and that could be 10 to 14 days before we actually get them out of a post-op splint into a brace. We're going to have a range of motion phase that's going to last, somewhere between, depending on the surgical indication, up to 16 weeks. And then from there, we're going to go into a strengthening phase, and so on and so forth until we get all the way into a return to throwing phase. And then from there into a mound throwing phase if they're a pitcher, and then a return into game phase, which, would be somewhere in the 10 month to 12 month down the road.
Yeah. And that is exactly, it takes a village mentality to bring one of these athletes back. Do you feel that the athletic trainer plays like a central role in all of that and making sure that everybody is working together in the same focus and the same process to make sure that they come back healthy and strong?
I do. I always think that, the sports medicine department is the liability for the organization, the portion of the organization that really tries to protect them and try to enhance basically what's going on. You're the connector, if you will, the connector of hubs to try to make sure that we're treating that athlete with everything that we can, from the abilities for them to just recover on a daily basis, to keeping a good mindset and a good outlook, and staying positive, because that's so important to the recovery and them actually getting back and being successful.
You touched on range of motion and strength and conditioning and strength training, and as you're moving into the throwing aspect, can you dive a little bit deeper into what you look for out of range of motion early on, when you feel you need to have range of motion after surgery, when you feel it's safe to return? How much conversation do you have with that surgeon during those early processes? As athletic trainers, we're always trying to push the envelope in a safe and effective manner for our players. So what kind of benchmarks do you look for, and what kind of communication are you having with the surgeon and the rest of the team?
Yeah. So for me, the big thing is, when this player's coming out of surgery, they're going to be in a post-op splint for probably a good 10 to 14 days. At that point in time, there's no sweating, there's no getting that post-op area wet. We want to minimize risk of infection. We want to keep the area clean, dry, etc. And they really can't do anything. And so they're going from a state of being extremely active to a state of really not doing much. So there's a lot that needs to be gone on there with giving them a little bit of, I guess you would call them hugs, if you will, to make sure that they kind of understand that they're loved, they're cared about. We want them to, have goals, and we're on the same page with them in having those same common goals. Once we get out of that post-op brace and we go into, or post-op splint and get into a brace, we usually set those parameters at 0 degrees of extension and about 120 degrees of flexion, or maybe a little bit less flexion, depending on the physician. But we want to try to attain that range of motion as quick as possible. We usually have some baseline measurements of what their range was prior to an injury. And so we want to try to attain that same range of motion as quickly as we possibly can. We don't worry as much about extension as we do about flexion. We really try to limit flexion immediately in the past about 110 to 120 degrees for about 2 to 4 weeks, and then we build that last bit of flexion in the next 2 to 4 weeks before we completely get rid of that brace, somewhere between 6 to 10 weeks based on the physician. And we try to, hopefully we'll attain that range of motion by about I'd say that 8 week mark, if you will. And then we're looking to go into a strength phase. And in that strength phase, we're going to look to probably from about week 8 to about week 16, we're going to try to regain as much of that strength and again, continue to work on that range of motion up until we get to about 16 weeks. When we get to that 16 weeks, we're going to probably implement a 2-hand plyometric program for about 4 weeks on an every other day basis until we get to about the 20-week mark, and then we're going to look to incorporate a 1-hand plyometric program for about another 4 weeks on an every other day mark. And then when we get to the 24-week mark is when we're going to hopefully start to look to an interval throwing program progression.
So I'm going to probably put you on the spot here a little bit, but a good 20 plus years ago as a student athletic trainer, you gave me advice about my first UCL reconstruction rehab and kind of gave me some pointers and things to look out for. And I've remembered them ever since. But to that point, where have you seen Tommy John and Tommy John surgery and the rehab specifically changed over those years? How have you seen it progress, regress? How has it been better or worse in your mind? And how have you changed how you look at the injury and the surgery now than you did maybe earlier in your career?
I think I've learned to slow it down a lot. When I first got into the game back in the late 80s, I think when you would think of a Tommy John surgery, you would think 3 months, 3 months, 3 months. And that's like 3 months of rehab, 3 months of strengthening, 3 months of throwing. And, that would put you at about mound phase, and that's about 10 months. I think we've really slowed that down by at least 2 to 3 more months, where we're thinking more of a 5 to 6 month range of motion and strengthening. Still probably about a 3 month throwing phase, and then another 3 month mound throwing phase. And that puts you at about 12 months right there before they're even probably getting into a game. The other thing, I think we had the success back in the 80s and 90s to get the player back to compete and be successful at the same level they got hurt in. Where as we got into the 90s and the later 90s, you're seeing these guys get back to the next higher level of and being successful. And then in the 2000s, the sky became the limit. I think we had this thing pretty figured out, and guys were having it as an amateur and getting to the big leagues. The guys were getting hurt at low A ball and getting to Triple A in the major leagues and being successful. And I think as we got into the 2010s, we saw players that were having multiple Tommy Johns. And I think we're seeing a trend where at one point in time, those Tommy Johns were lasting a good 10 years. But now we're seeing them pitch longer, but I'm also seeing a decrease in the length of those Tommy Johns lasting. And I think it's probably gone down to 8 or even 6 years before they're having to have a second or Tommy John or some type of surgical procedure again for articular issues or joint arthritic conditions or even loose bodies or bone spurs.
Yeah, we have definitely seen an uptick in surgeries in general as primary surgeries, but also in the revisions. And obviously your team physician, Dr. Neil Elatrosh, and Dr. Keith Meister with Texas Rangers are at the forefront of the hybrid technique, which is a newer technique for UCL reconstruction. And they're constantly looking at ways of making it better, making it stronger, making it last longer. So where do you see the surgery, the rehab, the return to play process going for the future? Do you see that we're going to continue to go more conservative? Do you feel like we're ever going to get to a spot where this is so commonplace that we know exactly when players are going to come back and they're going to do well? And what is your thought process of where this surgery goes in the next 10, 15 years? And what are we looking at for our athletes then?
I think we're at a scary phase right now because I think the emphasis is on velocity. And if you're not emphasizing that as an organization, then you're falling behind. But if you look at players nowadays, all they want to know is what was their velocity, what was their spin rate, what was their metrics per pitch. And I think it can be a good thing, but it can be a bad thing from our side of things on a selfish note, because I think that's where we're starting to develop a lot of these issues. The use of tack on the hands, or sticky substance, or the inability for them to use sticky substance and them having to pull down harder. I mean, we're kind of in a trend where it's a little bit frightening for me right now. I think I err on the side of conservatism when it comes to these now, and that's in conversations with Dr. Elitros, Dr. Meister. I mean, the majority of his physicians all over the country, because I think that's kind of where they're going at. These guys are throwing, sliders and curveballs, and now you got the sweeper, and there's so many specialists as far as like grips on the pitch and what do you do with your wrist and things like that. So, we're going, every team's going out there to win, man. And it's kind of a win at all costs and do whatever it takes. And in doing that, I think we're seeing some pretty scary stuff going on in that, and injury wise with these players. And, I don't think it's going anywhere. That's for sure. So I think these hybrids and these internal bracing techniques that they're coming up with are definitely warranted and needed to help strengthen a lot of these structures a little bit better if we can.
Yeah, it's definitely a different frontier than it was 15, 20 years ago. And we're just trying to do our best to try to steer these youth athletes and the athletes coming up in the best direction to stay healthy and go out there. So to that end, what would you say to a young athletic trainer that's just getting into professional baseball or baseball in general, and maybe looking at their first Tommy John rehab and their first UCL reconstruction surgery? And what advice, what pitfalls, what would you say to them to help them in their journey on their first Tommy John rehab?
I think the fun part is the coming into each day not knowing what you're going to expect. What's going to be the surprise of today? And being able to just have the attitude that, you're going to pull out your bayonet and charge up that hill and do the best that you can with that athlete. You're going to care about that athlete. And you want him to know that you're on his team and that you're out for his best interest. And I think to be patient, there's some tough love involved in trying to push him into what you're trying to attain for that day, to have small goals, to keep the physician involved and updated, because that's important not only for you to have that documented as far as liability, but also because it lets the player know that you care about them. So I think the big thing is to pay attention, because not two individuals that I've ever been involved in, and I've kept pretty much every player that I've been involved in their rehab, in either from the beginning or during the course of their rehab. And I've had the pleasure of being in over 150 different pitchers in my career. And I think the fun of none of them being identical. And I've always enjoyed trying to put the pieces together, the puzzle together. I think that's what's driven me. And so I try to instill in them to try to enjoy that part of it, and trying to figure each guy out and how you can push them, when to let up on them, when to push them a little bit harder, and when to know they're ready to move into the next phase.
Well, Ron, I want to say thank you for not only giving us your time to talk about this subject, but also for everything you've done for PBATs and for professional baseball athletic trainers everywhere. Do you have any closing remarks that you'd like to share with the audience to really drive this subject home, or just baseball athletic training in general?
I think the big thing is, when you get involved in athletic training, the fun part is, do you want to be good or do you want to be great? And if you can push yourself to be great, that's going to instill in you the want to learn, the want to see what's going on, the want to communicate and collaborate. And that's what's going to drive you. And if you really want to be good at something, it's going to take you at least 10 years to really get good at it. And if you want to make money as an athletic trainer, it's not going to happen on the front side. You're going to have to be persistent and stay with it, and hopefully things will pan out for you. But it's going to take time, man. You got to be willing to want to care for people.
Well, thank you, Ron.
Absolutely, it's been my pleasure, man. I've enjoyed this, and I've been fortunate and blessed to have a career that I've been able to have.
Thanks for listening to Inside Athletic Training's Tales of the Tape, the Tommy John series. Make sure to tune in next week as we sit down with Joe Bench, head athletic trainer with the Tampa Bay Rays, to talk about return to play plans and strategies after Tommy John surgery.